So good evening and welcome to the Reset, Reform and Recover event. So just a bit of a reminder about using Zoom. We are recording this event, so please be mindful of that. You may want to put your video on or off, it's up to you. But do please make sure your microphone is on mute so we don't get any background noise. If anybody wants to chat throughout the presentation, please do that through the chat function. It should pop up my screen, and if it doesn't, I'm sure somebody else that's on the call will kind of alert me to that. And if you'd like to actually come in and have a conversation, please use the raise hand function, which you can find along the toolbar at the bottom. Obviously, if you're dialing into if you're watching this again, those functions aren't available. So why did we decide to discuss reset, reform and recover? So we recognise the massive impact that the pandemic's had in the pharmacy sector. You know, the ongoing pressures and challenges that people are facing are massive, and they are ongoing. So we had the obviously landing of the pandemic in the March, but it does feel that now, although the pandemic, because of vaccination, is in a different stage, it doesn't feel to have gone away, and the challenges facing community pharmacy teams do remain. We've had some reports and information that's been backed up by the All Party Pharmacy Group report around the financial pressure that community pharmacy is under, and the report they published in December 2020 outlined that 9 out of 10 contractors felt that their place of work was under financial pressure, and they also feel that there hasn't been enough financial support, and there is concern around pharmacies closing because of the financial pressures. And because of this, as a committee, we did discuss, you know, what do we do about this? We wanted to share how some different contractors have responded to this and link you into some key information resources, which hopefully you might find help you and your pharmacy team be more resilient, reset some things, kind of think about what you're doing and what you could do differently to make sure that you are viable going into the future. Henry Ford, quite famously quoted, has got a quite famous quote: if you always do what you've always done, you'll always get what you've always got. And I kind of want to reflect this from a community pharmacy perspective. So, you know, we are doing an amazing job. We're doing a fantastic job for the NHS and serving our populations and community, but we're facing the challenges that we have just outlined, and many more. I'm aware there's many more than I've outlined in my brief overview. So some of the challenges that we've heard, as I say, I'm sure we haven't got them all. In fact, I know we haven't all, but are that there's more work, there's loads of patient queries. You know, the NHS is moving how you're paid in community pharmacy from items, and there's a shift now towards paying for services as well, clinical services as part of the 5-year plan. We have flat funding within the contractual framework, and all the PS&C are negotiating really hard to look for an uplift in that. We are still currently working with flat funding. Workforce is a real issue. It became very acute over the summer holidays, finding locums and people leaving community pharmacy for other roles. We're underfunded. Branded generics and prescribing changes still seem to be happening, which influence margin. GPs continue to be the focus of the NHS. And all in all, really, it leads to pharmacies being less viable, working harder for less. So we asked people to input just a few words at the last meeting we did with this topic as to how people felt about this and our challenges. And I'll share with you a word cloud of some of the responses. I'll let you have a look at that for yourself. I'm sure some of those things really resonate with you as well. And you know, what is our response as community pharmacy to this? You know, our reaction, quite rightly, is that it's not fair. We need to campaign for more money. You know, why have GPs got additional money? We haven't. Why are we not recognised for the work we've done? We get the words from those in Parliament, but we actually don't get the follow through of funding. It's really, really frustrating. So that is quite rightly our response to that. However, I wanted to give you a bit of a reality check, and you know, it is a bit of a hard message, but we do see ourselves at Community Pharmacy West Yorkshire as being your critical friend, and we want you to thrive. This is where we come from this. The difficulties we're facing, that is the reality. That is what we've got to work with. PSNC nationally are negotiating really hard to make changes, and we can see some of those, they're making some progress. So we got the opportunity to claim our COVID costs. They weren't just given to us, actually pharmacists could claim what they've actually had as expenses. So we have seen some changes, but we're not, you know, complaining about that locally isn't going to change those things locally for us. Questioning where we are and how we got to, I think does help a little bit because it makes you feel a bit better. It certainly makes me feel better when I'm happy about something. But complaining just to each other in our own little echo chamber isn't going to help make things change. So I would suggest if we keep doing what we've done, we're going to keep getting what we've got. And we do need to start thinking about how we do things differently and new to make sure we get change. Because if we change nothing, nothing will change. So as I said, the whole idea of this event is to share with you from other contractors some of the changes they've made to try and adapt so that they can be viable, to try and do things differently so that they can overcome some of the challenges they're facing. So first of all, we're going to hear from Mo, who's our chair at Community Pharmacy West Yorkshire, and he's going to talk to us a bit generally about things, but then a little bit more about prescription delivery. So this is where I have to hope the technology works here, and if it doesn't, then can somebody shout out if they can't hear and see Mo. So over to Mo's video now.
All contractors are financially challenged as a result of recent years of funding cuts to the community pharmacy contractual framework. And as a result, we're all having to find ways, new ways of working so that we can actually balance the books, and in many cases to survive. I've had a look at what we do in our small group of pharmacies and to determine how we may be able to make some savings in some of the operational aspects of what we do. So for example, with regards to managed repeats, we've asked patients to take more ownership for ordering their own prescriptions and for following up with their own queries to surgeries where, for example, they haven't quite received the number of items that they had requested from the surgery. We've made changes to our dossier dispensing policy, for example, and we've made amendments to our prescription delivery service. With regards to the prescription delivery service specifically, we've broken it down into two strands. First of all, any new patients who may request to join the service, and then secondly, any existing patients that are already on the service and how we can work with them. So any new patients, we now do a more thorough needs analysis with them. So if they're young and fit, we'll ask them to come and collect. If they're older, will they have a good support network with them, around them? So if they live with families, if they have friends, neighbours, we'll help them with their other routines such as shopping. And perhaps they have carers. It could be paid carers, it could be social carers who are assigned to them to help them with their daily routines and their care. So they can be expected to collect prescriptions for them. With regards to existing patients, we've communicated with them. We've explained the pressures that we face financially. We explained that the delivery service is not an NHS service. That is something that pharmacies do voluntarily and out of goodwill. And that if we're to continue providing it, that we need their support and we need them to make some changes. So for example, we ask them to order all their repeat prescription items that they require in one go. If they had prescriptions that were not synchronized previously, we've asked them to speak with the surgeries to have them synchronized so they can order all their required items in one go. If there's more than one person in the household, again, we've asked them to order together as a group so that we can just come out to them just the once. And we've asked them to collect ad hoc prescriptions in between repeats. So it could be for PRNs, it could be for acutes, for them to take more ownership for single item prescriptions that might come in between their regular repeat prescriptions. And then we've also looked at how our drivers work, delivering to existing patients. So is there a way that we can improve on that? And we've decided that we will deliver locality by locality. So sometimes you have a patient who says that they would like their prescription at a specific time in the morning, and somebody else from a different locality will also have a requirement to have their prescription at a specific time in the morning. So we've spoken to patients to be able to manage that. So now our drivers will not zigzag throughout the day. Instead, they will move by locality to locality and in a circular fashion, if you like, if you're looking at a map, so that they're actually able to deliver more efficiently and finish their job sooner. And then we've also looked at prescriptions that arrive in a fragmented manner with us by EPS. So patients who order all their repeat items together, but for whatever reason, we receive them from the surgery in a fragmented manner. So we'll receive 3 or 4 items one day, and we might receive another item the following day. So we now hold back on some repeat prescriptions, particularly if we know there's a history with that particular surgery or with that group of patients, that their prescriptions arrive in a disjointed manner. So we will hold back delivering to those patients for a further 24 hours. And then often we do find more prescription items arrive for them, and therefore we will deliver to them in one go. So these are some of the things that we've done to improve our delivery service and reduce the costs associated with it. But I'm aware there's more potentially that can be done, and so it is something that is in mind potentially going forward. So contractors I know that have moved to a alternate day delivery service, so Mondays, Wednesdays and Fridays, and patients are having to get used to that. Some contractors I'm aware that have stipulated a minimum number of prescription items, so for example 5 before they will deliver to patients. And of course we know many contractors have now started charging for delivering to patients. These are all things that are in mind potentially going forward as next steps for us to take in order to be able to balance our finances as a result of the funding cuts. And I guess it's a real shame, as well as the contractors, the people who are ultimately having to put up with the losses as a result of this are patients, and you know, in many cases they have had to take the brunt, like contractors have had to do as a result of the cuts that have been implemented onto community pharmacy. That is sad. I wish there was a way around that. Unfortunately, it's put contractors in a very difficult position. If we could have continued the way we've always done, I would have loved to have done that. Unfortunately, we are having to react and make amendments to our service offer. And potentially there may be more going forward. We shall see. Thank you for listening.
So Thanks very much to Mo for recording that and taking the time to share his thoughts and some things he's seen happen across. Apologies if Mo's lip sync was out. That's something which we haven't been able to correct. And I'm aware that actually, depending on where you're holding your vision of me, I might have blocked Mo out. So apologies if I've kind of overstepped on to Mo. I had to watch me, not him talking. So just a few key points Mo's made just to pull that out around delivery. Delivery is not an NHS service outside the pandemic delivery requirements, which have been extended till March 22, but only for those that are self-isolating and have a code. I think really helpful to see what others are doing. We have put on this slide on the right-hand side around the messages that we've been giving at Community Pharmacy West Yorkshire, that if people want to have their prescription delivered, be really clear that pharmacies aren't obliged to do so. They should ask a friend or relative first, but noting there may be a charge for that delivery.
All contractors are financially challenged.
Sorry. So the next one. So we're moving on now. Does anybody have anything they want to add about deliveries or anything they've heard that before we move on? No. So moving on to multi-compartment compliance aids, the MCA, which we also call MDS, DSET, trays. There's a lot of different terminology, but the term that we're using currently and hope to stick with in West Yorkshire is MCA. So Ashley was kind enough to record his thoughts on generally on things, but also to around MCA. So I'm now going to play Ashley's video for you.
Good evening. My name is Ashley Cohen. I'm a community pharmacist of a contractor from East Leeds, and I'm a member of Community Pharmacy West Yorkshire. I thought it'd be useful to highlight to all contractors some basic principles around the provision of monitored dosage systems, otherwise known as MDSs, nomads, or compliance trays. Before I start and go into any real detail, it's essential that each and every one of you as contractors and professionals reviews all the work you are currently doing and ensure that you or we are adequately remunerated for all the services that we provide. We have a contract in place that clearly defines what is reimbursed and, most importantly, what is not. We cannot afford to be busy fools, adding extra workload without adequate remuneration. It is up to each individual pharmacy to decide if they have the right staffing skills, the space, and the ability to safely manage and dispense MDS for their local community. The sole decision to supply medicines in an MDS is that of the pharmacist, not the prescriber, nor the patient or carer. Each pharmacy will make their own determination regarding MDS for an individual patient. However, there are plenty of template assessments available to help and support pharmacists in their assessments. Personally, I've been using the one on the PSNC website, and I find it really useful. Historically, community pharmacy has done increasing numbers of MDSs, but with the current underfunding of the pharmacy contract and without additional payment to fund the provision of MDS, many pharmacies are now unable to sustain their current level of MDS supply. As a consequence, pharmacies have no choice but are reducing their offer of medicine supplied in a compliance aid to those patients who meet the Equality Act requirements and where an MDS is considered to be a reasonable adjustment. Now, it's important to stress at this stage that pharmacies cannot use 7-day prescriptions as a mechanism to quote unquote fund MDS. So it's vitally important that you do not use or quote the "I need a weekly prescription in order for me to do an MDS." However, there are ways in which you may be able to better liaise or communicate with your practices and agree locally the benefits of 7-day prescriptions for patients on MDS. And these are in terms of maybe the following. Number one, to ensure adequate weekly deliveries and to help those that might be confused or at risk of an overdose. 2, to check for compliance, to able to feed back to the practice if the patients are not complying with their medication prescribed. In our pharmacy, we will contact the practice immediately with any concerns of unused medication when we pick up and collect old medication trays. 3, to potentially reduce wastage if medication is changed. If a monthly prescription are provided and medication is changed during that period, then a new prescription would be required for all of the medication. And fourthly, if set up correctly with electronic repeat dispensing, there is no extra work required from the GP practice, and it does not impact on their own practice drug budget. My personal view is that it's important to have a really good working relationship with your local practices around MDS supply. When you discuss the issues you face as a contractor and as a fellow professional, and you outline the service required for ensuring the safe management, dispensing and checking of an MDS, and you indicate the time involved in potential risks, I have found practices are willing, in the main, to be supportive, especially around agreeing local policies in regard to weekly prescriptions. Asking practices for their support and understanding as to why you are providing the service, the parameters you're working towards, I find is greatly appreciated and helps to bring down sectorial barriers. In my own pharmacy, I agree that for every potential MDS request, irrespective of where the referral comes from, I do a DDA form and share this with the practice. This is very much appreciated and provides the practice with the evidence of the DDA taking place for their records. I also review DDA each year as circumstances might often change, and I quite often move patients off from MDSs back to original packs because of convenience rather than need. When I do this, it again is appreciated by GPs. If a patient has started using an MDS because of convenience and not for general clinical need, I attempt to discuss with them options that might be better suited to support them. For example, MAR charts, using the phone as an alarm, or apps as a reminder, or simple routines and timings of when to take the medication. MDSs are certainly not income generating when you consider the time required, both in terms of management, dispensing, checking and delivery, and also the additional equipment which is also not reimbursed. Providing this service against a majority of 28-day prescriptions is simply not affordable, and in today's climate should not be done routinely or in large numbers. There's plenty of resources available on Community Pharmacy West Yorkshire website to help and support you all in this area, so please feel free to review these in more detail. I hope you found this area of interest and wish you all the very best.
So I need to give my thanks to Ashley for taking the time to outline his thoughts, his approach and how he tackles MCA with patients and how he's reviewed the way he provides MCAs. So some key points just to go through. Don't forget, you know, there is the Equality Act, but as Ashley says, it's about doing an assessment. Does somebody qualify under that or not? And it doesn't mean you have to necessarily give them an MCA. So you might want to do a large print label or a medicine reminder chart, for example. I think I know a lot of you are put under pressure to provide MCA from various people. It might be carers, it might be a family, it might be GPs. But do remember the liability for inappropriate, inaccurate and unsafe MCA also lies with you. So if you give somebody an MCA, it's not the best adjustment for them. You're the one that's provided that adjustment. So do just question just doing an MCA without considering, is that the best thing for that patient? Is there something that's safer for them? A reminder that many medicines, once you remove them from the original pack, their integrity is impacted and they are less than suitable for MCA. These are really good, and the link's on our website, but I've also got on the slides here, medicines information resource, where you can look up drugs and it will tell you how stable a medicine's likely to be in an MCA. I think what was key in both what Ashley and also what Mo said about making a change is discussing that with patients. It is always less contentious to introduce a new policy to new patients because they don't know what happened previously. So that's often where some pharmacies start, is by doing things differently for new requests for delivery or for MCAs. If you are going to review MCAs for existing patients, do be mindful that you need to have a conversation with the patient so they understand what's happening. And also, don't just say no. If somebody asks for an MCA, a blank no is also not a very safe thing to do because it could be challenged. So make sure you do make a decision. It doesn't mean you have to say yes, but you do have to make a consideration, and do keep a record of that. So Ashley did outline, we've got quite a few resources on our website, and we do keep adding to those. It's always worth having a look. We've got the MDS Contractor Guide, which is a 2-page guide, which is basically some of the facts about MCA. For example, it's the pharmacist's decision, not that of the GP, carer or anybody else. And some of the fiction about it too. So for example, if you get a prescription for 28 days for an MCA patient, you will give them 4 trays at once for 28 days, and you cannot be expected to deliver that weekly either. There's an MCA notification form which allows you to notify prescribers that an MCA is in use, and if there is a rationale for a 7-day provision, for example, the medication isn't stable, if you supply it for 28 days, it can help justify that too. Knowing that you get lots of requests for MCAs from paid carers and demanding that it has to be in an MCA, that is not the case. That's not supported by CQC or the guidance from the local authorities. So we have some information for you that you can use in your conversation with paid carers should they be demanding MCA from you. We've got the 7-day prescription guide, outlining when 7-day may be appropriate. But as Ashley said, just because it's in an MCA does not mean you demand a 7-day prescription. There has to be a clear rationale behind that. We had a previous event too, which may have a bit more detail you can find on our website. PS&C website is the other place I'd look. It's got the information about the Equality Act. It's got both a quick reference guide and a more detailed one if you want to know some of the detail. And there has, in the last few months, been a new decision aid, which is on the RPS website. It's come from the University of East Anglia, quite easy to use, and could be what you might want to adapt to use in your pharmacy. So moving on now to dealing with prescription orders and queries. So Amanda recorded a video for us around how they deal with orders and queries in her pharmacy. So I will now play that for you.
So when the pandemic started, we found that we were having to deal with a lot of phone calls during the day, mostly from people wanting to order prescriptions, which was very disruptive. Obviously, every time the phone rings, somebody's got to break off what they're doing and go and answer it. And that's not a safe thing to do in the dispensary. You want to limit your interruptions as much as you can. A lot of the surgeries near to us had asked people to order their own prescriptions a few years prior to the start of the pandemic. But some were a little bit more relaxed about enforcing that than others. So we still had a lot of people placing orders of those that were quite capable of ordering themselves. So we decided to encourage those people to order their own prescriptions from the doctors, either online or popping the order form round to the surgery. A lot of them were just dropping them into us anyway, so it didn't make a lot of difference for them to just pop it round to the doctors instead. And most people were okay about it. Some were a bit reluctant, but in general, they've all kind of started doing that now, and it has made really a really big difference to us. We're not getting half as many phone calls as we used to do. And it also means that if there's any problems with the order, if anything hasn't turned up or it's not quite what they ordered or something like that, then we don't have to deal with that as much because they haven't ordered it through us, so we're getting less grief as well, which is always a bonus. The other tip I would say is that if you get people ringing up because they've ordered something and an item is missing from the prescription, which happens quite a lot, instead of just going to the computer and looking on there and saying, no, it wasn't on your prescription, because it's usually quite difficult to get on the computer anyway if it's anything like our pharmacy. Just to try saying to them, have you got your order form there? Can you find the item that's missing and see what it says next to last issued? There should be a date, and usually it's an old date because they haven't done the prescription. So by doing that, you're sort of showing the patient how to look for that information themselves. So if it happens in the future, you won't get that phone call. They'll find the information for themselves and sort it out with the surgery. So that's my other tip.
So thank you to Amanda for taking the time and sharing how they are doing prescription orders and queries. Really helpful to hear how you're doing that. A couple of things I wanted to note. Amanda didn't mention them, but it kind of because to do with prescriptions. I wanted to remind you all we've got the branded generics letter, which is on our website under the dispensing page. It outlines to GPs, if they are using branded generics, the impacts of that, not just the financial impact on us in community pharmacy, but also the patient safety impact for patients. So just thought that might be helpful for you to know if you haven't seen that before. And also the NHS app, it's really helpful to encourage your patients to use the NHS app because they can use that usually to order medicines directly from the GP practice. It can help them track what's been ordered. And also it shows them very clearly who the nominated pharmacy is, so they can actually have that real, be in charge of their own nomination without having to ask somebody else to do that for them. And lastly, we're going to, David gave us some tips around income and efficiency. Now, sorry, David, are you able to talk to this, or do you want me to go through some of this and you can add? Shall I start, David, and you can add? So increasing income, you know, there is income out there. It is tough, but actually there is ways that you can increase your income. So if it's available to you, do make sure you get the most out of PQS and the new medicine service. That is part of the global sum. If you don't get it, it will go elsewhere within pharmacy, but not into your pharmacy. CPCS and the discharge medicine service isn't so much within your control because you're very much reliant on referrals from other people. At Community Pharmacy West Yorkshire, we're working really hard to try and get the hospitals to make more discharge medicine referrals, and also working with the GPs to embed the GP CPCS into routine practice. But think to yourself, you know, how can you maximise the number of NMS that you deliver? And have you thought about the potential income from NMS? So we've had the changes now to increase the threshold for NMS, and actually there is much more potential income to come from NMS. And a bit of a word of warning, really. If we think about medicines use review, which are no more, you have to ask yourself some why didn't they continue? Because they were good for patients. And I think we need to reflect that they were commissioned for 15 years. And even after 15 years, we only ever managed 75% of the maximum MURs that we're able to do as a global community pharmacy resource. And the NHS, who is our commissioner, are the people that set these services up. I do wonder whether that had an impact. So I would really say to you, particularly around NMS, look at the opportunity and do grasp that. Also think about how you can work effectively and efficiently. Do make use of your team members' skills. Delegate, make sure the person's got the skills and the competencies, but delegate where you can and where it's safe to do so. Think about your PMR. How could you use your PMR to be smarter? To what could it do for you? How could it reduce your workload and be more efficient for you? And if your PMR doesn't do it, actually, when you come to renew and do look around, some PMRs do an awful lot more than others. So do talk to other pharmacies around you to see what they use. Don't leave money on the table. Make sure you endorse correctly. Do submit your NMS and submit your claims on time, and check you're paid accurately. And there are some tools to help you do that. Given the financial uncertainties, it may be a good idea to consider your accounts and your interim figures and look at your cash flow, just because we know things are really tough. So yeah, don't wait to the end of the year to find out how you're doing. Think about that now. David, would you have anything else to share about that?
Yeah, I think one of the things I would suggest you do is just take a step back from the dispensing bench and just look at how you dispense. So we've just said, you know, your PMR, you're paying money every month for your PMR, and we're probably all guilty of only using about 30% of the functionality of it. And the other one is look at, you know, printing tokens? Do you need to print? You know, one of the biggest overheads in the dispensary is probably toner cartridges for printing tokens. You know, there are different ways of handling electronic prescriptions, especially ERD, that you don't need to print tokens. So it's not necessarily bringing in more revenue, but it's actually saving on outgoings. And we're all used to dealing with green bits of paper in our hand, but, you know, perhaps take a step back and think, can I work differently? And to give those efficiencies in your pharmacy. So ERD will allow you to work at times where you may be less busy, which frees up time in the busier times that you may be able to do a service. So you can have things ready for when patients come in rather than doing them when they're stood in front of you. And that just frees up time, makes you more efficient, and then allows you to do all the other things. And the other really important one is use the electronic services that are there. So, you know, make sure that you use the electronic NYS service to submit all your claims. You know, moving forward, make sure you've submitted them on time so you get your advance earlier. You know, it's not going to get any more money into your pharmacy, but it may help your cash flow. So it's use the services that are there to free up time to make your life easier.
Thank you, David. I really appreciate you collating those top tips for us to put on the slides, and also for your update now. That's really helpful. So I don't know if anybody had anything else that they wanted to share. If you are happy to share that, and knowing that it's been recorded, I'll leave it a quick pause so somebody can come in and come off mute. No, that's fair enough. There's not many people on this recording anyway. So that's kind of been really helpful to hear from others. I hope you've found that that's giving you some ideas, giving you some food for thought. We have Community Pharmacy West Yorkshire made available free of charge to you a Reset and Recover programme. Now this we did record over a year ago, but it's really helps you focus on reintroducing services in a COVID context, knowing that COVID is not going to suddenly disappear. So this is all available, I think, through our website. If you go onto the website, it's on the training tab. They are still available. It's a program, so there's 10 different sections you can look at. It does work best if you start at the beginning, work your way through, but you can just do them in whatever order you wish to do them. So as I say, it's been delivered by Deb Evans from Pharmacy Complete, who has done a lot of work nationally around pharmacy and how to be effective and to make changes. So please do consider using that resource. It won't be up there forever. So have a look and see if that gives you some ideas as well as to how you restart services alongside COVID. You may also want to think about engaging with your GP. You might think, your MP. You might think, well, what's my MP going to be bothered about? But we need to remember our members of parliament are our members of parliament. We all vote for them. They represent us. And they are the ones who, when there is debates about health, will be adding to that debate and will ultimately get to vote on things. What we want our MPs to do is have an insight into community pharmacy and to understand us a bit better, because if their own experience of pharmacy has been that maybe they're younger, maybe they don't have a long-term condition, they just walk in, they maybe buy some non-pharmacy related products and occasionally buy something for a cold sore, they're not going to understand the great levels that we go to for our patients. They're not going to understand the whole breadth of services that we offer. They also aren't going to understand how hard it is for you out there at the moment. So engaging with your MP is a really good way of them understanding a bit more about community pharmacy, and also hopefully them if there's a debate and community pharmacy is part of that debate, or primary care or the NHS, them being much more on side with community pharmacy. We have seen throughout the COVID, we have been liaising with our MPs, and I know some of the contractors have, and there's been several letters written to ministers challenging what's happening with pharmacy. So it is worth your while. And to make it really easy, there is a tool on the PSNC website where you can just click the APPG tool. It will find your local MP. It even populates some text for you to put into the message, although you can amend that to add on whatever you'd like, and you can quickly send it. So do consider engaging with your MP. It is more powerful than you probably realise. So to kind of bring us to a close, to change or not, survival is about who adapts the best. Step back and look at how you're being paid, and actually proportionately invest your time where your funding exists. You know, your community pharmacies are part of the community, and I know many of you are, you know, really part of that team. But take a step back, try to be objective, look at it like an outside investor. Do think about what you can change. Now, I know when I talk to contractors about changing things, for example, people ask me, do I change who I offer MCA to? And I outline very similar to what we've discussed tonight. They say, yeah, but if I don't do it, the pharmacy down the road will do it. And indeed, competition does divide us, and it does limit our progress. So think about how you can work with other pharmacies to help manage the same issues. Can't agree that we all do one thing once, because that, you know, that would be a cartel. But what we can do is you can think about what's best for your patients, and you can talk to others as to how they're managing it, as we have done today, just so we can learn from each other and adapt from each other. We need to work together more. If we're divided, we're less powerful. You know, patients don't understand why things vary between pharmacies, and I kind of get that. And working with other pharmacies can be really tricky. I really get that too. I'm not saying it's going to be easy or without risk, but actually do find a way of working with other pharmacies around you. You know, if I think about PQS and flu, so that's part of the funded conversations, to kind of talk to each other at what you're offering with flu. That's a really good way to demonstrate how you can work together to better understand each other's services. And think about how, you know, we support each other. So for example, if you have somebody to come to you for emergency contraception, for example, and either you don't do the commission service, or the pharmacist that's there, you know, isn't able to do that day, don't just say to somebody, oh, we don't do it. Make sure you find, you know, check with the pharmacy, see if they do it, and signpost to them. Send the other work to pharmacy, because actually we do need to support each other. So going back full circle to where we started, if you do what you've always done, you'll always get what you've always got. But in addition to that, if what you are doing is not working, do something else. So I would like to just bring this to a close and say thank you very much for your time tonight. I hope you found that helpful. Again, a massive thank you to committee members for taking time to record the videos and sharing their experiences. If you need to contact, hopefully you know how to now, but that's one of the ways you can do it, by emailing it, or the Community Pharmacy West Yorkshire Connect on Telegram. Thank you and good evening.